Okay, so it's 3 minutes past the hour. Welcome again to this new webinar organized by the Maternal Health Supplies Caucus. Please remain muted to prevent background noises. My name is Milka Dine, and I'm the technical lead of the Maternal Health Supplies Caucus, which is currently chaired by Emma Clark from USAID. This webinar is being recorded, and a link to the audio and video will be sent to all members of the Maternal Health Supplies Caucus, as well as to all participants in this webinar. The webinar recording will be stored in our website, in our library, so you will be able to access it anytime at your leisure. You're most welcome to write your questions in the chat box at any time. So please, as soon as you have a question, make sure you remember it and write it in the chat box. And without further ado, let me introduce our moderator today. We're very lucky and honored to have Dr. Doris Chu, medical officer on the maternal perinatal health team of the Department of Sexual and Reproductive Health of WHO. Doris has the overall coordination of the maternal and perinatal norms and standards. Doris completed her postgraduate training in obstetrics and gynecology and in maternal and fetal medicine at Johns Hopkins Hospital and at the University of Pennsylvania. Doris has a very long CV, but I just gave a few highlights. So Doris, the microphone is yours.
Thanks very much, Milka. And good morning, good afternoon, good evening, good day, in fact, to colleagues and friends. It's really a pleasure to be here with all of you. Thanks, Milka, for that very kind introduction. And thanks to you and your colleagues at the Reproductive Health Supplies Coalition for convening us here today to discuss the use of oxytocin. This is the second of a series of webinars that are designed to identify country challenges, some potential solutions and best practices in training, communication, and supportive supervision for the appropriate use of uterotonics. I mentioned this is the second in this series. Some of you on this call may have already participated in prior discussions during the first webinar that was held in April of this year, looking at accelerating access to heat-stable carbetocin for prevention and for as well as TXA for prevention of postpartum hemorrhage. And in that webinar, while the focus was on new uterotonics and how there might be learnings on how to introduce these new uterotonics, especially after a formal recommendation has been issued by WHO, I think it's always good to look back and think about what is our current use, our usage of current, or what we might consider our standby uterotonics. So I happened to check, and of the over 300 individual recommendations that the team that I'm working on, the maternal perinatal health team, managed, a quick check showed that over 20 of them say something about the do or don't regarding the use of oxytocin. And I think in some ways we have to acknowledge that that is relatively theoretical. You have a recommendation that says something, but I think what we will hear today will be two real-life experiences regarding the use of oxytocin in two different country settings, Nigeria and India. And I think for this group, in many ways, profiling these two countries and the understanding of the challenges faced could bring us a long way in preventing maternal mortality and morbidity. Just to remind the group, Nigeria and India together have the highest number of maternal deaths. They account for almost just over a third of estimated maternal deaths the last time this exercise was undertaken. And so any intervention that affects the health outcomes of women in these settings will really have a palpable impact, not only in these countries, not only for the women and communities there, but quite honestly also regionally and globally for our collective goals. So I'm going to introduce our speakers just prior to their their interventions. Our first speaker is Dr. Choma Ikejoma. She's going to describe the findings of a cross-sectional study that was undertaken in Nigeria on the patterns of use of oxytocin across facilities. Dr. Ikejoma is a consultant, public health physician. She's an expert in pharmacovigilance and pharmacoepidemiology. She also has a very long CV, just to say that she lectures, she undertakes research. She has over 17 years of experience in the field of public health. And she's really been using her knowledge and her energies to look at grassroots and high-level advocacy to ensure safe and quality-assured medications in Nigeria and Africa. She has a current project on the use of uterotonics across regions in Ghana. But today, she's going to be describing her findings as a lead investigator on the USAID PQM program of the US Pharmacopoeia Oxytocin project in Nigeria that looked at quality perceptions, experiences, and the use of oxytocin from healthcare providers and their perspectives. The floor is yours.
Thank you. Thank you. Let me share my slide. Okay. Okay, do you see it now?
Perfect.
Great. Perfect. All right. So thank you, Doris and Milkan and everybody on the call, Megan, and I'm very pleased to be here. We had shared some parts of the findings of several years of work in the oxytocin space in Nigeria. So today, I'll be sharing our finding on the pattern of intraperitoneal use of oxytocin injection. This, I must say, we've done several studies, but this finding hasn't been shared in any global space or scientific meeting, but an aspect of it that focused on prevention of postpartum hemorrhage had been published in PLOS ONE journal. That was last year. But this aspect were sharing intraperitoneal use of oxytocin. Okay. Sorry. Great. So we all know that oxytocin is the drug of choice, according to WHO, for the prevention of postpartum hemorrhage. However, evidence has shown that more women actually undergo the intraperitoneal use. You know, there is high use of induction and oxytocin, using of oxytocin for induction and augmentation of labor to deliver babies. And this inappropriate use of uterotonics for labor induction and augmentation has been documented globally with rising incidents, including in sub-Saharan Africa, especially with the continuous rise of global efforts to expand access to uterotonics to prevent postpartum hemorrhage. So with that effort comes the high intraperitoneal use. So for better understanding and for all of us to be on the same page, induction of labor is a process of artificially stimulating the uterus to start labor. And WHO, in their document, Induction of Labor Recommendation of 2018, recommends the use of prostaglandins for induction of labor, and where not available. By the way, that document was meant for under-resourced settings. So to put it in context, where it's not available, intravenous oxytocin alone should be used. Induction of labor is usually performed by administering oxytocin or prostaglandin to a pregnant woman or by manually rupturing the amniotic membrane. Okay. And the augmentation of labor is a process of stimulating the uterus to increase the frequency, duration, and intensity of contractions. This is after spontaneous labor had commenced. And it's usually used to treat delayed labor, where poor uterine contraction is assessed to be the underlying cause of the delayed labor. And the traditional method, according to the WHO document recommendations for augmentation of labor of 2014, is to use intravenous oxytocin infusion or amniotomy. Now, we have mentioned earlier while we are here today that oxytocin has been demonstrated to be frequently used for intraperitoneal induction and augmentation at all levels of the health system, including primary healthcare facilities. And this comment is important because A lot of country protocols, recommendations and guidelines guard against its use, especially at the primary care level in low resource settings, because of the kind of the level of skilled or cadre of health workers that are usually available in these areas. Okay, so we know that with induction and augmentation, intrapartum use, I would say there is an increased risk of the woman having bleeding, the pregnant woman having bleeding, consequent cesarean section, uterine hyperstimulation and rupture, fetal distress, and a large systematic review has linked intrapartum use to of oxytocin to neonatal encephalopathy. So the general comment is that there must be the use intrapartum must be practiced with caution and must be carried out in facilities where cesarean sections could be performed and where there are highly skilled health manpower. We have this, some just picked some high data available that intrapartum use is used as much as from about 19% to 15%, 51% of institutionalized deliveries in both high and low middle income settings. And sequel to this large study done, this what we're presenting today, was actually a pilot study done in Lagos. Lagos is the center of excellence in Nigeria with the highest population of all the 36 states. And that finding actually made us want to see this picture, what's the picture going to look like, what's the pattern for the larger nationwide study. So it reported that about 68% of the respondents had reported use of oxytocin for induction of labor in the last 1 year, and about 80% for augmentation of labor. I just put in the paper, it was published in PLOS ONE. And in this same study, the dose often used for augmentation of labor was about 32% used 5 international units, nearly 49%, 10 international units, and about 3 to 3.4% of them used doses ranging from 30 international units to 60 international units. And I must mention here, because I have so much but so little time to share, this data was even disaggregated, used in primary gravida and multi, and that is the caution, or even some countries, some South Africa would say do not use a multi gravida. It has a intrapartum use of oxytocin, but this was similarly used in both primaries and multiples. So this current study was a descriptive study. We surveyed over 6,000 healthcare providers who deliver babies from over 2,000 healthcare facilities from across Nigeria. And these health facilities were from both the public and private sector setting, and at the 3 levels of the health system: tertiary level, secondary level, and the primary care level. So I mentioned that it was a large study that assessed knowledge, practices, perception of quality, clinical experience, and the pattern of use of oxytocin in healthcare amongst healthcare providers. So this is just an excerpt from this finding, reporting on the intrapartum administration. So what did we learn? On the administration of oxytocin, we saw that who are the cadre of healthcare providers who most administer oxytocin. And we saw that in public health facilities, it was majorly the community health workers. The community health workers we surveyed here were the groups they call community health officers and the community health extension workers, right? So these are lower level of healthcare providers. They administer oxytocin most in the public health facilities. And for obvious reasons, in the private setting, doctors were administering more. Then what did we learn about indications for use of oxytocin? Generally, 78% use them for prevention of postpartum hemorrhage. 68% of the respondents use oxytocin for augmentation of labor, and 53% for induction of labor. And if we disaggregate and looked at the healthcare providers who use this, what is very important here, we see the doctor's pattern, but if you look at the nurses and the community health workers, you see as almost 40% of them actually use oxytocin for induction of labor, and 49% of this use oxytocin for augmentation of labor. And I must say, why I'm focusing on this within my timeline is to highlight that these care of health workers actually are not authorized to use oxytocin intrapartum. We have a document, a policy in Nigeria, a task shifting and task sharing policy that actually do not authorize their oxytocin use intrapartum in this group of health workers. Then what did we learn on route of administration? We saw that 92% of the respondents used intravenous infusion when they want to use oxytocin for induction or augmentation. About 10.3% use intramuscular route for induction and 9.4% in intramuscular route for augmentation. And 8% of them similarly use intravenous push for both induction and augmentation of labor. And we know that the recommended was intravenous, okay? What were the dose often used, the pattern? About 38% of them, of respondents, use 5 international units for induction of labor, and 48% similarly for augmentation of labor. But as much as, about 47% use 10 international units for induction of labor, and 44% 10 international units for augmentation of labor. And we see what I just picked out of 20 international units. So in conclusion, our study provided evidence or described the pattern of intrapartum use of oxytocin among the different cadres of healthcare providers who deliver babies, over 6,300 of them. There is a wide variation in the amount of oxytocin used or infused, and oxytocin is documented to be used intramuscular for both induction and augmentation of labor, which is not part of the recommended route of administration. And our study further highlighted the high intrapartum use among healthcare providers, especially the community health workers who are not authorized to use oxytocin intrapartum. We all know, and while we're here, their common interest is that quality maternal care is centered on the need to reduce avoidable maternal and neonatal morbidity and mortality. And there is need for a global position. There is need for a global position on total or maximum amount of oxytocin that should be infused. Hence, a strict recommendation is needed on the use of uterotonics for induction and augmentation of labor. And as new uterotonics are being introduced, we recommend that it's important to ensure the right indications for use and the appropriate skill manpower are clearly communicated. So I think I would pause here for now. Thank you for listening.
Thanks very much, Dr. Kajam. I think you've given a very nice overview of the experience that you had in Nigeria. Now, I'd like to pass this to our second speaker, who will share a sub-analysis of the Better Birth study, which compared the effect of a coach-based implementation of the WHO Safe Childbirth Checklist to existing standard of care on a composite outcome of maternal and neonatal outcomes in the days after birth. Megan Marstellini is our second speaker. She's the scientific lead with the Better Birth program at Ariadne Labs and a research scientist at the Harvard T.H. Chan School of Public Health. And she provides scientific leadership to a portfolio of projects related to improving the quality of care. Before this, she had another life, and she served as a nurse advisor for the Ministry of Health of Palau. She's worked to build nursing technical capacity and to implement evidence-based changes to childbirth and emergency care. She has had experience in implementing an implementation research in Sierra Leone, and she's also worked as a clinical nurse at Johns Hopkins Hospital. Knowing all those sites, I don't know which one she would say it was the hardest one, but just to say that I think what you will have to share with in regards to the sub-analyses from the Better Birth study in India, which looked at intra and postpartum use of oxytocin as one of the components of the essential birth practices, will be quite interesting for this group. Over to you, Megan.
Thank you so much, Doris. Let me take a minute to share my screen. Great. Well, thank you so much for that introduction and for the opportunity to present to this esteemed group of people and to share some of the findings on uterotonic use stemming from the Better Birth study in India. everything going. There we go. I'm fortunate to be part of Ariadne Labs, which is a joint center of innovation that sits between the Harvard School of Public Health and Brigham and Women's Hospital here in Boston, USA. Our vision is that health systems equitably deliver the best possible care for every patient, everywhere, every time, which I think has really helped to drive some of the work that we'll be presenting today, that I'll be presenting today. And before I get started, I want to recognize all the partners who have contributed and supported the overall Better Birth study listed on the left there, as well as the co-authors on this secondary analysis as we dove deep into uterotonic use and mined the data that we could find from the study. Now, some of you might be familiar with it, but the Better Birth study was a cluster randomized controlled trial that tested the effectiveness of a coaching-based implementation of the WHO Safe Childbirth Checklist on perinatal mortality, maternal mortality, and severe maternal morbidity within 7 days of birth. The study included the 7-day health outcomes on about 160,000 mother-newborn pairs and includes data from just over 5,000 directly observed births. In short, the intervention was based on the Safe Childbirth Checklist, which includes 28 essential birth practices, including the administration of oxytocin after delivery to prevent hemorrhage. The checklist was paired with engagement of district, state, and facility leaders, a motivational event to launch the program and train healthcare workers on the checklist at each facility, and 8 months of peer-to-peer coaching of birth attendants. And you can see at the bottom there, it kind of started very intensely twice a week and then tapered across the 8 months. Now, the results of the study, the trial found that the intervention increased adherence to evidence-based practices, but found no difference in the 7-day health outcomes. Now today, because I want to talk to you about augmentation practices that were observed during the study, I want to give you a little bit more context about what we know about the primary level facilities that were part of our study. So these facilities provided care to an average of about 1,600 women annually. That's about 130 a month. And the cesarean rate among these births was under 2%. And that included the women who were referred out from these primary facilities to a higher level, a district level or above. So very low cesarean rate. The birth attendants who worked at these facilities included mostly nurses and auxiliary nurse midwives, and they provided the majority of the care. And mostly obstetricians were not present in most of the births that were observed. And on the mother side, I just wanted to note that we were able to document the time of arrival at the facility to the time of delivery, and it was a median of 105 minutes between arrival and birth. And so you'll hear me talk about oxytocin use, intrapartum oxytocin use, and mostly refer to augmentation, because that would be a very fast start to finish induction in 105 minutes. And although we have very limited data from the study on community use of oxytocin, this was a common voiced concern among the nurses who were part of the Better Birth trial. Now, while the overall study was much larger, today we're going to look at a subset of the 5,484 births where a direct observer was present during the interpartum period, which took place at a total of 30 facilities, and that's 15 intervention and 15 control. Now, notably, the use of oxytocin for induction or augmentation is not on the checklist, the Safe Childbirth Checklist, but we collected data on this due to its potential influence on health outcomes. Through this direct observation, we used a standardized data collection tool to document adherence to a series of behaviors, including in-facility oxytocin use before and after delivery, as well as observed use of neonatal bag and mask. In a subset of these cases, about just under 3,000 woman-baby pairs, we compared perinatal mortality associated with women who received oxytocin versus not. And we didn't stratify that by intervention versus control because of a low sample size. And finally, we looked at supply availability that was collected during quarterly audits to better understand the general availability of uterotonics during the trial. Now, the government of India has very clear guidelines, great guidelines, on the recommended use of uterotonics at primary level facilities. And these guidelines state that the use of uterotonics to induce or augment labor at these facilities is not recommended. Oxytocin, and in some cases misoprostol, is generally provided to these facilities only for the purposes of AMSTIL or management of PPH. So they're definitely there, but they're all for after the birth of the child. So what do we find? Oxytocin was available at about 70% of the facilities, including both intervention and control facilities during the trial. And we collected that every quarter, as I mentioned. About a quarter of the facilities had a fetoscope or a Doppler to monitor fetal heart rate. And in looking at oxytocin use before delivery, you can see the change in use over time. In this graph, I just want to take a minute to orient you. The y-axis shows us the percent of observed deliveries where oxytocin was administered before delivery. And the x-axis shows the various time points with regards to the intervention. Baseline, 2 months after the start of the intervention, 6 months, and 12 months after the intervention. And the 12-month point actually happened about 4 months after the intervention ended. The blue line represents the intervention facilities and the orange line, the control. At baseline, we see that almost 80% of women received oxytocin for augmentation, very similar to what Dr. Choma found in her study. There's no agreed upon expected number of cases where augmentation should be used, but I think we can agree that it should be far lower than 80% of cases at a primary level facility. Routine augmentation in these intervention facilities decreased after just 2 months of coaching and stayed lower than control even after the end of the intervention. But notably, the use of the partograph, which is on the checklist, and that would really look at contraction patterns and fetal heart rate and monitoring and documenting that, was used in less than 1% of cases in the entire trial, regardless of how much coaching and support was used to implement that. Now, just to highlight the oxytocin use immediately after delivery, since this was the intended use in these primary facilities, you can see the same graph set up with the blue line representing the intervention facilities, orange line control. And at baseline, only about a quarter of the women in either group received oxytocin immediately after delivery. But again, adherence, which is good, which is what we want, increased dramatically after 2 months in the intervention group and stayed higher, intervention stayed higher than control even after the end of the intervention. In looking at health outcomes, we saw higher perinatal mortality in cases with augmentation versus not, although this finding was just above our significance cutoff of 0.05. We also saw that augmentation was associated with significantly higher use of neonatal bag and mask after delivery. Now, after the trial, we also conducted verbal autopsies to find out more about the babies who had died who were part of this observed cohort. And you can see that birth asphyxia is the leading cause of death, most notably on day 0 of life in these facilities. Now, on the maternal side, we attempted to look at any association with oxytocin use either before or after delivery and maternal hemorrhage, but there were too few cases in the observed data set to do a meaningful evaluation. In the overall trial, just for reference, we found that about 7.5% of the women did experience hemorrhage within the first 7 days after birth. Other findings that I thought might be important to mention here. One is about the route of administration. And really, about 3/4 of the women received IV oxytocin during augmentation. Now, our data collection tools, thinking that it would mostly be infusion, didn't specify infusion versus IV push. So that was one kind of gap. We're not exactly sure how it got into the vein. And about a quarter of them received it intramuscularly. In terms of other uterotonic use, data was only collected after the end of the intervention, so at that 12-month period. And so it was excluded from analysis. But in that time period, we found that misoprostol alone for augmentation was used in about 12% of the cases, and that multiple uterotonics for augmentation were used in about 7% of the cases. After delivery, misoprostol was used in about 5% of the cases, methergin at about 3%, and more than one uterotonic was used in an additional 5%. You can see the limitations from this study. Direct observation can have a bit of a Hawthorne effect where people are being observed, and yet we saw very high rates of administration. We don't have any data on community use of oxytocin, and we don't have any, because we had kind of fly on the wall observers, we don't have dose or potency of the oxytocin that was administered. Great. So in conclusion, in-facility oxytocin use to augment labor was high in this setting, despite poor maternal and fetal monitoring practices or the ability to intervene in the event of adverse outcomes or fetal distress. The Better Birth intervention, which included the WHO Safe Childbirth Checklist, coaching, and data feedback, was successful at decreasing intrapartum oxytocin use and increasing use immediately after delivery. Ongoing supports needed to maintain these practices over time, though. And additional efforts may be needed to communicate potential harm to the fetus resulting from unmonitored use of oxytocin during labor in order to decrease patients' demand for oxytocin and birth attendants' administration of oxytocin before delivery. And I think that the de facto use of uterotonics for labor augmentation, even when they're not recommended or condoned by the government or health ministry, is really important to consider as other uterotonics like heat stable carbetocin are more widely introduced. So I want to thank you guys so much for the opportunity to present today, and I really look forward to the question and answer. And for any questions, feel free to reach out, and as well, the related manuscript for the work that I presented is listed here. So thank you so much.
So thanks to both of our speakers. Milka, did you have you received other questions?
Okay, we have a question from Metin Gulmesoglu from Concert Foundation. Metin is asking if you have the same data for misoprostol, especially for induction in the same study. I think he's asking Chioma for this.
Okay, we didn't look at other uterotonics in this study. Our focus was on oxytocin use for postpartum hemorrhage prevention and intrapartum use as well. But I've forgotten the name. We look out for when we are done with a very large study in Ghana, you would have something on misoprostol use and other uterotonics. So I'm looking forward to what we're going to be finding. Thank you.
Thank you, Chioma. Philippe Becker is asking, did you gather any data on the availability of oxytocin at the facility level? That's you, Megan, I believe.
Yes, thank you. And I believe that was clarified later in the presentation, but I was curious to know maybe kind of if you had further details on that.
So the overall availability of drugs and both drugs and supplies, we found increased slightly throughout the trial in both intervention and control facilities. One of the things that we found is that because some of the advocacy from the individual facilities happened at the district level, that whole districts started to improve in terms of supply and drug availability. So we didn't find a big difference between intervention and control because that is not controlled at the facility level. So again, we found about 70% of the facilities did have oxytocin.
Great, thank you for clarifying that.
Wonderful. then yes, we will be sharing the presentations as well as the recording. And as I said in the beginning, you will find this recording in our webinar library at the RHSC website. Another question here from Metin. For increased perinatal mortality in women receiving oxytocin, were you able to adjust for risk factors like post-term pregnancy and other issues?
So I think I'll take that one. So the short answer is no. The challenge that we faced was that most of our health outcomes, the 7-day health outcomes, were self-reported from women. And those were kind of the most routinely checked. From the facility registers, we were able to collect some information about women and their delivery process. But that was really based on what a nurse was able to provide, and that wasn't clinically rechecked as well. So it is taken with a grain of salt. We didn't have data on kind of the gestational age or at what point a woman was able to give birth in terms of post-term pregnancy or other issues. So we didn't feel confident enough in the data to adjust to it. So that is a limitation that we had.
Keith Hummel, was there any testing or confirmation of the quality of the oxytocin and if it was stored appropriately?
Okay. I could share, I don't know if Megan has any information on that from her own study, but they wasn't part of the focus or the scope that I'm presenting today, but part of the larger study, we actually did, there was a laboratory quality assay done before this, right? That actually spurred on us wanting to know what the healthcare providers, who are actually the end users in the supply chain, but very important end users, by the way, to assess quality. So the laboratory assay actually found that 74% of the oxytocin available in the Nigerian market at the time were of poor quality, right? But the finding further analyzed that it wasn't the reason for that poor quality finding was actually a storage issue, degradation, not actually from manufacturing or other assays. I mean, laboratory assays have been done where your API content was lower. So it was down, realizing that the reason for the degradation was more of in the storage level, that we now wanted to know the healthcare providers who would use this, it was a proxy assessment of perception of quality. And our proxy assessment was now looking at it from the dose that is being used actually. You know, for prevention of postpartum hemorrhage, 10 international units is recommended, but we had a high proportion using between 30 to 60, and their reasons were straight that when they give the 10 international units, it wouldn't give them desired contraction, right? So when they increase that dose, they get that. So that's a proxy assessment of quality in our study, but we've done a direct and objective laboratory quality assessment. So that's what I would say on that response if it was done. Of course, knowledge on the storage, assessing even knowledge from the healthcare providers, do they know the appropriate way of storing? And I could tell you here that knowledge was poor across cadres of healthcare providers. We found that about 52% actually knew that it was meant to be in the cold chain, right? Stored between +2 to 8. So that could have actually, if they do not know in the spectrum of knowledge and your practice, they didn't know that's the appropriate storage requirements. And that could have consequently affected the practice.
I can talk a little bit about the study in India as well. We didn't do any testing of the oxytocin, but we know from the coaches who were there in the facilities there were a couple of issues that kind of came up. One was that it's not stored in refrigeration, or that it's not stored during the day in refrigeration, so that you have it more ready to use. At some of these smaller facilities, they don't have many refrigerators. And so it's kind of stored with the vaccines, which is in a different part of the facility. And so to get the oxytocin over there in time, to keep it in there and then get there in time when you have limited staff is just a logistical problem. So that was one of the things that we worked with on the study of how we could, keep it cold and keep it in the labor room so that it could be taken out. And I think it's just one of those problem-solving strategies for these smaller facilities as getting those systems in place were really important.
Thank you, Choma and Megan. I have another question from Tama Kamlem from the PSM project, Gemonics. Thank you for 2 great presentations. A question for Dr. Choma. Was the study able to find the reasons motivating healthcare workers to not stick to global guidance issued by WHO? Were health providers aware of the limitations and contraindications of oxytocin use?
You asked of were they aware of the global recommend? What spurred their trying to practice practices against the global recommendations? Yes, it was simply that they don't get the desired contraction. I mentioned that in the first comment. A lot of them knew the recommended dosing, but they just feel that the oxytocin available isn't of higher quality. So they need to have they have to use increased dose to actually get the desired contraction to prevent postpartum hemorrhage. In fact, I think when Megan was presenting, it's just this is an aspect of a wealth of rich data, and we are focusing on an aspect. But something she mentioned that we saw again was even combined use of uterotonics. That's an entirely different focus for another webinar. Where you have multiple use of uterotonic 2, 3 to do the same thing. So their reason for going against the global recommendation was that they feel the quality available, there's poor quality of what they have available. So they need to increase the dosing up to 6 vials to get the desired contraction. That's what our study could find. But again, we didn't go into trying to assess if they knew the implications of having to use oxytocin or the contraindication. We didn't go into that. We were simply looking at their clinical experiences. So it was more of, have you experienced this kind of thing, complications, the listed complications from failure to achieve desired contractions or using multiple doses of uterotonics. So those were things we assessed.
All right.
Okay.
Thank you, Choma. Robin Churchill is asking, given the exceedingly low use of partograph in the BB trial, was there any sense of individualization of oxytocin augmentation, or did you analyze use by provider? And for the Nigeria work, was the partograph use studied?
So in terms of the Better Birth study, we didn't find any individualization. We tried to connect, what had been written in the register in terms of complication or any kind of, any status of the mom or fetus that would have indicated, oh, this could have been a reason why oxytocin was given. But we found no association with what was written in the register with any commonly accepted indication for oxytocin or augmentation during labor. We did not go back and analyze by provider because some of that data was masked. And so we did not do that analysis. And that was partially masked just to ensure, because this is not, this practice does go against what's recommended by the Ministry of Health, and we didn't want to put any of the birth attendants at risk or make them feel threatened through our observation.
Yeah, from the Nigerian study,
Megan.
we didn't. Sorry, Milka. In
No,
the
no,
Nigerian
go
study,
ahead.
we didn't study pathograph use or anything like that. Yeah. I just wanted to mention, somebody asked actual practice, we assessed the real, because assessed knowledge, knowledge could be different from the real practice. So the knowledge 52% poor, but in actual practice, only 34% of our respondents actually stored oxytocin in the right refrigerator. So that was what we found. We assessed that. I think somebody wanted to know that information. We did.
Lydia,
Most of the other
Eric.
people stored on the shelf. Most other people stored on the shelf, like mentioned, by Megan. Thank you.
Lydia Eric is saying, I'm alarmed, although not surprised by the presentation from Nigeria. We have anecdotal evidence of the use of oxytocin as intravenous push or intramuscular for induction and augmentation of labor. For this to be confirmed by a scientific study is cause for concern. I believe this must have some relationship to the occurrence of ruptured uterus. Which way forward then? Government has made laws to regulate the use of intrapartum uterotonics, but they are flouted with ease and without consequence. However, this scientific evidence should be something government can work with to improve vigilance and sanctions for flouted or fluted laws. My other comment is that it would appear that women like their labors to be short. What implication does this have for the implementation of the latest WHO guidelines on intrapartum care, which suggest that we are currently intervening too early and should allow labor to last longer if mother and baby have no adverse medical findings? Any comments?
Maybe if I
think
can
Doris,
come
yeah,
in.
yeah.
To Lydia and I think others who have noted these findings. As I said in the very beginning, this is the real life experience of what we're seeing from, a recommendation that comes out. And I think that there's a lot to unpack here. Besides having recommendations, besides having, Dr. Choma mentioned the issue of task shifting and task sharing. That's very clearly stated what is and what is not allowed in Nigeria. And this is true for other countries as well. But I think at the bottom, at the end of the day, we have to go back further and say, okay, so before we get to governmental sort of policy making issues on sanctions for flouted laws, it's an issue of how these attendant skilled health personnel are being trained. And this is another issue. I didn't bring it up earlier, but I think, if we look at the number of births that were attended by skilled health personnel, the last set of estimates that I have for Nigeria, it's under 50%. And that's where women, so again, there's a lot of flaws with the information that we're seeing. And so in terms of what can we do? I think there's a lot that we can do in terms of thinking about how healthcare workers are trained, how they're supported in their environments, so that they have a supportive environment to actually do what they're meant to do and not feel that they need to grasp at straws when they've gone beyond their level of expertise. That's one thing. I think having some of the commodities that we've been speaking about here actually being treated the way they're meant to be treated, meant to be in the instance of oxytocin and in cold storage is important, because if something is not as efficacious and it's being used, and then it's sort of being used more and more, you have this negative perception that maybe it's not working. The medication was never working, but maybe it was that medication was never going to work no matter what. And that's why Dr. Choma's work in Nigeria, looking at the safety and the quality of medications in Nigeria and Africa, is so critical. And I think Megan's presentation, which looked at the full spectrum of quality of care and all the different components, is really important to keep in mind. Remember that the use of oxytocin is just one of many essential birth practices, and it's not just one of, it's not just going to be one thing that often makes things go one way or the other. So I think there is a lot of space for better policies, but I think the issue of policies that result in sanctions, they can often have sort of a negative consequence. If I just speak to maybe reporting adverse outcomes, nobody likes to say an adverse outcome happened while they were, a woman was under their watch. I practice clinically, and others of you are currently. It's devastating. But to be able to go back and say, okay, now I need to report it. Now think about it, if in your country, you are penalized for reporting a mistake that you made, in all good conscience. Now, I think what Lydia, you were mentioning is something which is a little bit different, but the shades are quite close for reality and how they might be implemented in the other end. Just to your next comment in terms of the latest WHO guidelines of intrapartum care, I think what you're speaking about also is about too much, too soon, and too little, too late, which is a whole other topic that I think we could also try to unpack. And I think this is just part of the conversation that we want to have about how is it that we get into the minds and the hands of the people who are taking care of the women that we're trying so desperately to avoid adverse outcomes? What is it that we need to do to support them? I think what we've seen here is some of the results of scientific studies. I think the other thing that we didn't talk about here was the qualitative findings of what the healthcare providers would sort of come back to and say, well, this would have helped or this wasn't helpful, etc. To really try to understand how is it that we will change behavior, because at the end of the day, everything that I've read here in the chat, and I think what we've been speaking about in our two presentations had to do with the behavior of how a healthcare provider who was tasked to do a specific to take on a specific management, how did they do that? And with what sort of underlying interpretation did they have of what they were supposed to do on that day? So again, I think that there's a lot to still unpack here. So I think that, this is the second of a series of webinars. I see that we're coming up on the hour. And while I have the floor, if I may, Milka, may I just make my little announcement? I've said it to folks in the chat, but I just like to let you know that as far as induction of labor goes, WHO has literally just published 3 updated recommendations on the use of mechanical methods for induction of labor, the recommendations for outpatient settings for induction of labor, and for induction of labor at or beyond term. So not exactly the use of oxytocin per se, but just to say that recommendations are constantly being looked at. We are looking at them to see when we have new evidence that will change our recommendations for the better. And so I'm really pleased to share that with you because it's literally just happened. So I'm going to pass it back to Milka to give us closing words on behalf of the coalition. I'd like to thank the speakers from my side and to say what an honor it's been to be with you in this webinar. And thanks for all the questions and for all the attendees to share some of their day with us. Thanks from my side. Over and out.
Thank you, Doris, Megan, and Choma for this wonderful presentation. I think we've missed maybe 4 or 5 questions, but we'll be sending both the recording and the presentations to all of the participants. And I'm sure that you can email Megan or Choma with no problem. And Doris, we're waiting for those new WHO guidelines. So if you send them to me, I can share them also with this group and the caucus as a whole. Thank you
Absolutely.
so much. And please stay tuned to our next webinar. It will be the 3rd of this series. And we're hoping to give you good good news soon. Bye-bye. Thank you.
Thanks, everybody.
Thank you. Take care.
Everyone, take care.
Bye-bye.